Good morning, dear colleagues, distinguished guests. I extend my warm welcome to each and every one of you to our side event, which is organized by the Permanent Mission of Greece in Vienna and the Greek Organization Against Drugs, OKANA, to whom I express my heartfelt gratitude. Our gathering today centers around the critical issue of Greece's pioneering initiative in overdose prevention and access to services. The operation of drug consumption rooms or overdose prevention centers and their effectiveness have sparked an international debate. Our objective today is to shed light on the profoundly positive impact these drug consumption rooms have on overdose prevention. We will delve into not only the functioning of DCRs, but also the pivotal initiative of ensuring naloxone access for all to reverse overdose cases. Additionally, we will explore the establishment of a detoxification and overdose reference center in Greece and up-to-date research exploring the experience of individuals who use drugs within the context of DCRs. We are very happy to have here today the president of the Organization Against Drugs, Mr. Athanasios Theοχάρης, who will present our panelists and moderate the panel. Thank you all for joining us also through Zoom in this crucial dialogue on advancing innovative solutions for a safer and healthier future. I will pass the floor without further ado to Mr. Theοχάρης.
Good morning. Thank you very much, Mr. Sofos. I would like to welcome you all here in the room and the people who are watching us from Zoom. I would like to thank you, Mr. Sofos, and the Permanent Mission of Greece in Austria for all the hosting the organization that has been done, and it's quite an honor to have you with us here. So I will present here our people who are going to speak on an issue on DCRs, on drug consumption rooms, and I will start from our lady, Dr. Gillian Sorter. She's reader in clinical psychology in Belfast. Morning. And I have beside me the doctoral student Benjamin Scher, as well as Márιος Ατζέμης from the civil society and the positive voice. As a member of the civil society, active and always there for us. So today we will talk about the policies and all the movements and actions that we've done in Greece, and we will discuss some issues concerning how we created and how we did all these policies, as well as we will try to make a comparison analysis on what other countries can have done or can do. So starting with my presentation. Now, can we put it on full screen? Okay, sorry for the inconvenience. So let's see what the policy initiatives that we've taken in Greece. First of all, we had this expansion of naloxone use. We had only naloxone in hospitals, and we expanded the use of naloxone. We had established a framework for drug consumption rooms, which is very significant. And during this big changes. We've done a very important enhancement of harm reduction services and direct access services in Greece, which was also funded by the European Union. And the last but not least, we entered ESCAPE, a program of EMCDDA about syringe analysis. My personal experience from all these policy, let's say, initiatives and involvement was that we had a very good support of government and local authorities. The municipality of Athens, for example, was very in favor of the DCR that we opened, as well as we shall say that the message is that the DCRs meet people's needs. It's something that we should keep that in mind. And the key role of this is to have involved all people around you. So what happened? In 2021, we changed the framework of naloxone use, and we have all professionals that can use naloxone in the field. Till now, we have more than 450 professionals to have been trained. And till today, we have saved in using naloxone 230 cases. And from 2023, we had a last law that we have passed, and naloxone can be administered by all, which is very significant. The timeline of our DCR opening. We started around in April in 2020, and almost in 2 years, we had the opening of our DCR. We had the permission of a stable and mobile DCR in Athens. We've created the stable. The mobiles are in a row. And we have this happening during the COVID period. This means a lot. So this is our drug consumption room in Athens with all the equipment and all the stuff that we can use with safety. That's our motto. The DCR had a political support. As you can see, the Prime Minister of Greece and the President of the Hellenic Republic came and they inaugurated and paid official visit to the DCR, which is very symbolic and very important, not only for us, but for the international community as well. I don't think that there is also, you can tell us if there is also a president of a country or a prime minister that has given so much support in this kind of harm reduction services. It's quite significant. We had a very good media coverage, either from the inauguration, either for the operation of the DCR. And as the evidence says, almost 31,000 cases of supervised use have been done within the DCR the last almost 2 years that we we operate the DCR. And as you can see, we have 165 individuals that were prevented from overdose and 118 cases that were treated with naloxone use for their overdose. These people might have been dead if the DCR wasn't there. So the next steps are mobile DCRs. We will have 3 mobile DCRs in Athens and in Thessaloniki. And the one is funded by the European Union as well. And we have all this experience being implemented within the European network of DCRs, where correlation and EMCDDA will create. So we entered as well the ESCAPE project. The ESCAPE project is a project with syringe residues analysis, which gave us lots of things. We started with 2 cities, Athens and Thessaloniki, but we now have 5 cities in Greece, which is quite interesting. And we do it with the Aristotle University Medical School, where we can see the substances that there are within the syringes that are being used for drug use. These are some results that we found from the first. The second analysis is coming these days on. And for example, we found some in Athens that we have a combination of cocaine and heroin and one of methamphetamine. Or in Thessaloniki, we found that we had buprenorphine being used, which is a significant issue for us, and as well as the combination of buprenorphine and cocaine, having this quite interesting. So we made also from ESCAPE an interesting analysis on DCR syringes. We took syringes and we analyzed them, and we found that there are almost in at least half of the syringes have this so-called speedball, meaning that they have heroin and cocaine as well. And the most interesting was that we had all these new trending substances, the other opioids, as you can see, 11%, which are combined with heroin as well. That's why we have a new entry, a new input in our DCR, where we can check drug, and we have drug checking machine, and we can inform people how to use and how to have this better for themselves. After ESCAPE gave us all this very useful information, we decided, and the Ministry of Health agreed, to have the first toxification and overdose reference centers in Greece. And it will be situated in Thessaloniki, where we will respond for all the overdose cases from the country, and we will refer all the deaths due to overdose from drug use. This is very significant. For the first time in Greece, we will have a reference point where the professional from the Medical School of Thessaloniki will have this analysis and will give all the protocol for the handling of the cases of overdose or toxification in Greece. Here you can see also the enhanced street work actions that we have done as an organization. You can see the evolution through the years from 2020 to 23. And the most significant thing is that we have passed the 1,150 syringes distributed to the people who are doing drugs. And the condoms as well, where we reach almost 120,000 condoms distributed to the field. This is quite significant because it is not only in Athens, not only Thessaloniki, but also in 3 other cities, big cities in Greece, which meant that we expanded our network. And of course, the challenge was to overcome, to exceed the WHO average for the distribution per person per year. We have much more exceeded that average. We are almost 300 per year that the WHO sets to 200. So this is the work, and my last but not least is to I want to say to you is, don't be afraid of DCRs. They really do not harm, because people think so. They only reduce harm and save lives. Thank you very much. And we pass to Ben. Ben is will present his, let's say, watching our work and making another analysis, which was very critical for us, and it was very helpful in order to see how we work and how we can evolve our working.
Thank you very much, and good morning, everyone. Thank you very much to the Permanent Mission of Greece and to OKANA for inviting me to speak. We'll just get the slides. They'll come up in a sec. Okay. Great. Okay, so while we get set up here, so my name is Ben, and I'm a PhD researcher at the University of Oxford. And originally, my research started off as a comparison between Vancouver in Canada and Birmingham in the UK. So I grew up in Vancouver, and I wanted to do research looking at the experience of people in cities where there's an abundance of drug consumption rooms, like Vancouver, and then Birmingham, where there currently aren't any. And so I was just off the back of doing 3 months of ethnographic fieldwork in Birmingham when I was invited to do a visit of Athens's brand new DCR. So it had only been open for 3 months at that point. So this is on the 22nd of June, 2021. And I was very lucky to get a tour by the staff, including Mr. Theοχάρης. And the tour started off pretty much as I expected. So I came in, it was very well lit, very clean, ambient atmosphere. There are a few people using the different booths. We went over to the inhalation room. So on the left here is where people can smoke their drugs, and kind of carried on walking around other parts of the facility. These are the showers. But it was when we arrived at the communal spaces that I was really taken aback and surprised, because I've visited a number of drug consumption rooms. I've worked in them in Vancouver for a couple of years, but what was quite unique about coming to Athens's DCR was the communal spaces. So people who had just finished using were chatting, were playing board games, but they were interacting with staff as well. And so immediately I could see kind of the unique ability of this DCR to help people get in touch with on-site services. So in Athens' DCR, there are, I'll get to that in a second, there's counselors, there's medical professionals on site, there's psychologists, there's housing workers, there's really kind of everything that you would need for someone who's potentially living and using on the street to get connected with services. And so kind of the main quote from the tour that Mr. Theοχάρης said to me at the end of that was, we really do strive to have all the services under one roof. And that is really what kind of hit home for me. And so off the back of that, we decided with my supervisors, with Dr. Shorter and Mr. Theοχάρης as well, to add Greece to this analysis, to do a comparative analysis between the 3 locations. And so the research question was really kind of, what are the key strengths and weaknesses of this DCR, but also what is the experience of people who are currently still using in the street and not getting access to the DCR? So really kind of holistic angle, really based on the experiences of people who were using drugs. And so, yeah, just very briefly, this is kind of what the DCR has on offer. Like I said, a number of booths and inhalation services, a number of other services as well. So this was the methodology. So I worked with 2 local researchers, 1 peer researcher and a graduate student at the University of Athens. And we conducted 5 weeks of rapid ethnography, a number of focus groups, interviews with staff and management, and 25 interviews with people who weren't accessing the service as well. And so this is kind of an overview of the results. And so the focus groups were with people who came to the site nearly daily. They were people who had been recruited towards the back end of our kind of immersive ethnography, and so they were people who came quite regularly. And really, a lot of the evidence that came out from here was what's reported in the international literature. So people were really, really happy with the referrals that were on offer. They also felt a much greater sense of security and protection and safety, as well as enhanced feelings of connection with their other community members, and generally kind of spoke about the DCR in a really positive way in terms of the impact that it had on their lives. And so we'll look at some of the quotes now that people spoke to here. So the benefit is that you're not being chased by the police. The constant stress when using, especially if it's intravenous, you see the cops in front of you and you can easily do something wrong. As I suffered a couple of weeks ago, I was mid-injecting and saw the cops in front of me. I had to pull it out. I developed a deep abscess, which is still slowly recovering. It was incredibly painful. And so off the back of all of this research, we produced a report that outlined all of these quotes and all of our findings. And OKANA has taken that away to work with these sorts of quotes. And so we've got a few more here. So whatever we need and ask for, they help. For the bathrooms, for my clothes, if I need help with using advice, or even if I need a sleeping bag so I can sleep on the street, they will also give me blankets so I'm not cold. All this is very important to us. In the beginning, I wondered a bit why it exists, but then I came here and a member of staff showed great interest in helping me, from getting access to my benefits to whether I was interested in going into detox. So off the back of the interviews with people who were on the street, a number of recommendations were also made in order for OKANA to really understand how they could increase the number of people accessing the service. So this was really important for us as well. So firstly, just here are a couple. There were 12 main recommendations that were made. Firstly, distance from where people use. So the DCR is a fixed site at the moment. And so this person says 500 meters feels like 500 kilometers when you're sick. You don't have the time to do the paperwork, to see the doctor, or any of those things. So off the back of this, OKANA have taken this recommendation, and as you heard earlier, have now implemented and are planning on implementing mobile DCRs to get to these slightly more suburban and rural areas. The opening hours as well were a huge issue for people. When I first went to do this research, it was 9 to 5, only open during the week. Off the back of this recommendation, it's now open 7 days a week and open from 8 until 10. So again, much, much better coverage for people. And again, staff, but also people who access the site said that it would be useful to have a more formal process for peers to feed back on the delivery of services and to have more involvement. And this is also something that they're now taking away and considering. So I just want to finish with this quote, because this was something that a young man who had only come twice to the site before he did the focus group said to us, in this place, people treat you like family. They treat you like a human being. And I think this is the really important takeaway from kind of this sort of in-depth ethnographic research, is we can look at the number of overdoses reversed and the impact it's having on HIV, on Hep C, all of these kind of core outcomes. But at the end of the day, if people who are marginalized are feeling like they're being cared for and getting reconnected to society, that is also, for me, I see that as a primary metric that we should be looking at. Yeah, so finally, I just want to say a huge thank you to OKANA, to all the staff, to also my co-researchers, Christos and Nikos, to all the participants and my supervisors as well, and to the SSA for funding this research. So yeah, thank you very much.
Thank you, Ben. As you can see, we took into account all the things that you've said, and we tried to change some things. We are to change more, but I would like to hear now Márιος. Márιος Ατζέμης is a harm reductionist, let's say. He's very active. He's very well known in the civil society of Greece, and he has done a great work, especially on HIV services and treatment, as well as drug use. Márιος?
Okay, thank you. I don't have a PowerPoint, so you should focus on me. If it is okay with you. I have to say that it will be a very short speech and should be perceived as a statement, more or less. I would like to thank the Greek delegation for including me. Special thanks to OKANA and Mr. Theοχάρης. I'm Márιος Ατζέμης. I was working 10 years as a harm reduction officer for the Greek Association of People Living with HIV Positive Voice, a small grassroots organization based in Athens, but also the focal point for correlation, the European Harm Reduction Network for Greece. I am a member of the Civil Society Forum on Drugs, a consulting body of EU regarding drug policies and civil society perspective. And now I'm moving from my role to the civil society to the city of Athens as a consultant for the mayor for drug policies and bloodborne infections. So this is probably the last time I represent Positive Voice, but certainly it's not the last time I represent frontline workers and peer networks that strongly support and encourage peer-led harm reduction. I'm one of the recorded incidents that remain in the collective consciousness as the HIV outbreak in injecting drug users in the center of Athens between 2011 and 2013. No matter how many times I recall that period, I cannot forget what happened to us due to severe budget cuts as a result of the austerity measures, and how necessarily and life savings are the frontline services as a DCR. Over the previous years, a key area of our advocacy was the struggle to have a DCR in the center of Athens, a center with at least 3 different open drug scenes. When this finally became a reality, I thought it was one-way street to support this project by any means necessary, in every possible way, and I continue to do so. DCR might be the first structure that links with healthcare extremely vulnerable, stigmatized, discriminated, and marginalized people who live in a constant no man's land. Having that said, any criticism from the civil society perspective must be a constructive criticism, not a destructive one, and surely must not be expressed with inaccuracies and with social media rants as it happens in Greece, unfortunately. All people in the field and relevant stakeholders, we must be united and work collectively for a common cause without toxic confrontations. The society is changing, the drugs are changing, and we must be vigilant and ready to face all these challenges, all these changes. I have to remind to myself and to remind to you that harm reduction is about compassion, dignity, respect. It's radical love. It's about saving lives. We meet people where they are, but we don't leave them there. Thank you.
Thank you, Marius. You always remind us the hard way that it is to help people with a problem of drug use. I would like to publicly thank you for all the support and all the truths that you have shared with us.
Most welcome.
So we pass to our lady, last but not least. And she's Dr. Gillian Sorter. She's a reader in clinical psychology, as I told you, and she will tell us about this analysis that she have done.
Yes, thank you so much. I'm very grateful to the Permanent Mission of Greece for inviting me along to have a conversation with you today. There is a QR code on the screen. This allows you to download the report I'm going to talk to you about today directly from this, and it's on all the screens. So if you don't get a chance right now, there's still time before we end. Firstly, I would just like to acknowledge those who commissioned and published the report, Drug Science, my funders, and remember that this is the views expressed are those of the authors and not necessarily those of the funder, and of course my wonderful co-authors, without whom I would not have been able to produce this piece of work. So I'm really here to talk a little bit about the evidence. This has brought together 570 references, and to the best of my knowledge is the largest review of the evidence that we have on drug consumption rooms, safe consumption sites, and overdose prevention centres. For the purposes of this talk, if you'll forgive me, I'm just going to use overdose prevention centers, or OPCs, because to list them all takes a while. So I hope you'll forgive me and I recognize that there are legal and other distinctions as to why we might choose one over the other. But the report aimed to do 4 things. Tell us what an OPC is and why we might want one. We're going to talk about the evidence for OPCs in the report, how we might run or operate OPCs, and how we might evaluate OPCs, a very important component. So I think it's important to acknowledge, in the context of the wonderful work that's been happening at OKANA, that overdose prevention centres can be very diverse in how they are expressed in the communities in 17 countries around the world. But at their core, they are a place where people can use drugs obtained elsewhere and be observed by trained staff from an identified need in that particular community. And these are non-judgmental environments. And I think we heard so powerfully from Marius here about how important it is to bring marginalized communities in and to not leave them there. I love that final quote. And this is a picture of a van that was the first drug consumption room in the UK, run by Peter Crikant back in 2020. And this is a story. This evidence that we see in this report tells us a story, as we've heard today on this panel, about transformation, about meeting people's needs. And from the results of the Escape Project, this also involves not just the individual needs, but understanding the needs of the community. What drugs are people using, and what do people actually need? So what evidence did we find? We summarized 33 different reviews in short paragraphs, and we included 570 references. Not all were peer-reviewed. I just want you to know the quality did vary depending on the piece of the document we were looking at, but this is what we find overall. So we find that they prevent overdose deaths, and we've heard from the panel today, this is about harm minimization strategies, it's about immediate intervention, it's about naloxone supply and use, it's about a calming environment that supports individuals. We've also heard very powerfully about the importance of reduction in transmission and impact of bloodborne diseases, and we see the evidence very clearly for that through the mechanism of providing advice, sterile equipment, testing, and a safe place to dispose of used equipment. We've also seen the evidence in this report in communities by giving people somewhere beautiful, clean, welcoming, like we have in OKANA. We can minimize public drug use because we can bring people into a space tailored for them and reduce drug-related litter in the community. We also see no impact and no increase in crime, particularly when compared to control areas. Central to all of this is we have a lot of evidence that we can reach marginalized community members that other services are not able yet to reach. This can be due to stigma, trauma, previous negative experiences, or lack of awareness of the service. But bringing people in is a really essential function. And part of that is referring individuals to relevant services that meet their needs. I'm not going to pretend that this is not one of the most important levers that we have from a policy perspective. We can save a considerable amount of money for the public purse by reducing emergency healthcare, which is, as you know, the most expensive healthcare, by treating HIV, hepatitis, earlier intervention, we can see, and preventing death, we can create incredible savings for the taxpayer around the world. And we can contribute to real-time surveillance data to get an understanding of what's actually happening in the area. We've heard the incredible support, the political support we have in Greece for drug consumption rooms, and how this allows the service not just to sit around and go, are we going to remain open? But it allows it to evolve, it allows it to thrive. There are a number of challenges to operation that we discuss in the report, such as sending the wrong message. So one of the things around this is part of public health support for people who use drugs. And we know we are here because we are aware that drug use is a reality in our communities around the world. There's quite often a lack of public understanding of OPCs, and we've seen in Greece how the media have a good understanding of what's going on, and this helps raise awareness. Public opinion is very, very important, and conversations and partnerships are key. The role of evidence in policy, well, how much more evidence than you need than 570 references summarized in one helpful document with the QR code? And if you're interested in why sometimes we don't use evidence, may I recommend a book by Alex Stevens called Drug Policy Constellations, which looks at this evidence and moral dimension in policy making. Also, there can be resistance to expand provision and political support, but we're exceptionally fortunate in Greece that this political support allows services to evolve, grow, be better. There's a sense that we should be spending money only on abstinence-based treatment, but this is part of the bigger picture. And abstinence-based treatment is part of that picture. And DCRs and OPCs are part of the wider support. Stigma preventing service provision. We are all here. It is time to end stigma wherever we are. Stigma stops people accessing healthcare, improving their lives, and keeps marginalized communities marginalized. Meaningful engagement with people who use the service. Well, we're seeing here how the peer experience and the peer inclusion in OKANA is really helping enhance the service. And of course, legal matters is a key reason why we are here. So the evidence and the thing I'd like you to take away here, as with Greece and around the world in the 17 countries, OPCs can be transformational. We have the evidence for this when open to response for need. We can see change at societal, community, political, and individual levels. However, there is a vulnerability there. If we have a lack of political support, it stops services evolving, and or if we have a lack of peer engagement in these services, they're not then tailored to the community they're meant to serve. Therefore, strong support can actually reduce harm, save lives, promote well-being, give voluntary access to social, health, welfare, and other drug treatment. If I haven't convinced you, or if I have convinced you, either way, see the report by clicking on the link. It will be a direct download, or you can contact me on the email. Thank you so much for the opportunity to discuss with you today.
Thank you, Gillian. And I think that today we tried to see holistically the operation of a DCR, or in general the DCRs, and we have as a key role issue in our mind the evaluation and the operation of a DCR, which is also for us very significant because, you know, when you work, you see only the everyday things. You do not see, many times, you do not see the future, you do not see the evolution, you do not see always the needs that will come. And this is a role of the evaluation system and all the analysis that we can have. The basic as well is to have feedback from the field, from the civil society, and it's very crucial for us to know how the people feel from the services provided and how we can adjust our services for better in a better way. So if someone of you wants to ask us or to have any kind of.
Thank you very much. My name is Nico Clark. I'm an addiction doctor from Australia. And for the last 5-6 years, we opened a drug consumption room in my city, and I was leading this process. And I would like to support much of what you said. I think we tried to do a very similar model, really to be a place where people felt welcome when they came and they could receive all the services they need. And for us also, it was a very positive experience, and many people came. and many people benefited, and much of the feedback was very similar to the feedback that you received in your report. But maybe one difference I noticed was that no prime minister came, no premier came. We have a very, we have a culture war in our society, and a very active conservative media that produced more than 1,000 media articles about our centre in the years that I was running it, and this made the politicians very nervous, very scared, and they were too scared to come and say, I saw the video of your Prime Minister and President talking really compassionately about people who use drugs, and our politicians were too scared to do that. They said, well, we don't like drug use, but we don't want people to die. And at the same time that they invested in the drug treatment centre, they put more police in the neighbouring streets. So how did you achieve this? How did you manage to get the politicians to kind of make this switch to be more compassionate and to be more openly talk about it in this way?
So I have to tell you that first of all, we cannot share our Prime Minister. But he might support your effort. Secondly, before saying many other things, you have to know that we have a liberal government, which is quite, let's say, strange to hear that a liberal government made this kind of services. But the thing is that the Prime Minister, before he was elected, he went to the field, and we showed him the field work. How was the drug use in pavement, as we say, and he saw it during a very difficult period. So he saw all the situation, and he decided to have on his program and very high in his agenda the solution of this problem. We explained to him that the solution was to make a drug consumption room, and he was very positive from the beginning. We had the full support of the Minister of Health, and I have to say to you that we changed almost 3 Ministers of Health, with all the 3 Ministers of Health supported this action. After coming into action, the DCR, the Prime Minister was very in close, let's say, discussion and interaction. He was asking many times about the operation of the DCR, and this was really, really insightful for us as well. And he paid a visit. He came and he discussed. Márιος was one of the persons that were there. He discussed with the community. We had some ex-drug users, we had some drug users, and we have some users of the DCR. And he heard from the people who were using the place by himself. So he was not only convinced, but he supported, and he was asking, when are you going to create another one? When are you going to make other evolution like the drug checking machine and things like that? And you know that I noticed that in a meeting that we had another time, he asked me about the DCR. He was remembering that. And the other person that it was very significant for us, because it's like a big hug, let's say, or an umbrella in our state, it was the President of the Hellenic Republic. She is a former judge, which is, as you know, totally different way of thinking, judges. And she's from, not from the right wing, let's say, of thought. And she came and she saw the field. She went with us on street work. I think it's the first time that a head of a state went for street work. And she saw the problems. She spoke with people doing drug use in front of her eyes, which is very, very difficult to see it and to have it in your mind. But she decided to do it, and she inaugurated the drug consumption room. And despite the fact that the first time that she was going to inaugurate the DCR, she was ill, she wanted to do so because the symbolism of operating a DCR was on her top of agenda. Marius can say as well what it was the interaction, but it was a very good timing, let's say. And, you know, as I say, COVID period gave us much more challenges and opportunities in our field, in drug use treatment in Greece. Yeah.
I'm Nabisha Jurasovich from Drug Policy Network Southeast Europe. Congratulations for all work in Greece and DCR and naloxone that are big steps for Greece. One question. When you do analysis of samples of syringes, did you find fentanyl or nitazenes? Is some of these naloxone interventions because of that or no?
Yeah, it's our scaring movie, let's say, to find fentanyl. No, we haven't found fentanyl or nitazenes, and at least in these settings that they follow a specific methodology that the MCDDA puts, we haven't found any fentanyl or nitazenes, and I think only we have found in 2 or 3 deaths in Greece, but they are afterwards. Yeah. We have the honor to have Mrs. Sultani here.
Thank you. Oh, thank you very much. First, I wanted to thank all the panelists for your really excellent interventions and really congratulate Greece for all you've done. Really, this is amazing to hear about the evolution of the drug consumption room and how you have really made the situation much better and have evolved to include the measures to meet the needs. So this is really, really brilliant, and it's a best practice that I think we should really share more with countries. Your case should be shared with more countries. I had one question. I wanted to ask that question that Militant asked, but another question. Do refugees and migrants, do they have access to these services as well?
Yeah.
Thank you.
We have no exemptions. We accept all people who are coming to our door, and they are entered with great joy from us. Yeah, Marius.
Something to that. I had an enormous challenging project with Positive Voice and with major civil society organizations in Europe, with Mainline, with Correlation Network, and with the University of Barcelona, University of Ghent. And it was about migrants and refugees who use drugs. And for me, it was a real exciting experience because with the help of Mr. Theοχάρης and OKANA, I used their premises for personalized interviews, and there were many people there that were coming. It's open to everyone without any kind of discrimination or whatever, because now migrant population is getting more and more higher in numbers in the streets of Athens, and it's very crucial that the DCR and the drop centers of OKANA, are totally open to these people.
Sorry, I forgot to introduce myself. My name is Tariba Soltani. I'm the chief of the HIV/AIDS section for UNODC in Vienna. And just to add, we have the first time joint side event with UNHCR on Friday, where Mainland will be presenting this work. So please do come if you're here on Friday.
Yeah, thank you. Yeah. Yeah.
This is a very good work that you have done, yeah. And just to add is that we accept all people who are in need. And especially for immigrants or migrants, we've taken some actions lately, pilot, let's say, but significant, especially with people who use methamphetamine. Which is a very, very emerging and new trend that we have in Greece and especially in Athens. So we have made a special project within the detention centers of Athens, where people did not have any kind of medical support or treatment for drug use, as well as we try to bring these people within the drug consumption room in order to take all the supportive services that they need. And in addition to all this, we have a shelter and day centers in Athens and in other places in Greece where we can accept immigrants and people who are from abroad and who are either drug users or homeless only, and can be accepted and supported by our professionals.
Thank you. I'm Matthijs. I come from the Netherlands. We also have drug consumption rooms. I've been one a couple of weeks ago, and it was very inspiring experience. And one of the things they told me there was that everything is going quite well, but the detox part, so getting people to do detox or even stop with their addiction, is quite hard. So I was wondering, do you have any positive experiences? What can we learn from you? Thank you.
Yeah, lately in Greece we have 3 detox centers in 3 big cities, Athens, Thessaloniki, and Ioannina. But as a new process that we will be handled within the few months that will come, we will have detox centers within the general hospitals. As we pass a law now where we will have a big organization and we will have all the drug use treatment within that, and we will have in every city almost a detox center or a detox program, let's say, for the people who are in need. I visited your DCR a month ago. It was, I think, with a conference that you had in Amsterdam, and it was very significant experience.
I just gonna add to that as well. So during the research that we did, something that came out massively was that even though people were reporting that they weren't necessarily following through every single time with the referrals that were being made, they were grateful for those contact points, and they found it much easier to get referred on to whether it was detox or housing or counseling. And so I think there's something just really important in that with DCRs generally. It just increases the chances that people will get. People were saying that they'd spent 6 months to a year before on the street where they didn't know where to start if they wanted to see a counselor or wanted to get to detox. Whereas here, when they're engaging around their drug use, it was just, much more easy to do that.
And you know, the DCRs are the step that can take you to a detox center or a treatment. We have many people who came, as I say, the first client of DCR in Athens, within 1 month, he entered a program, an OST treatment program. And we have many cases that have been transferred to detox centers as well. It doesn't mean that someone who will use DCR will stay in the DCR services only. he can continue in treatment, in detox, in whatever he wants.
Hello, thank you for all the interventions. I'm Georgia Dimitropoulou. I work for UNODC on the crime prevention area. I have two questions. One partly is answer is also linked with the last point about the referrals. So I'm wondering if for the DCR in Athens, in the context of the evaluation that you did also at the profile of the users compared to the profiles of those that do not use in terms of age, gender, migration background, but perhaps also years of use or type of addictions and this, and if you can see who for whom is attracted, if I may say, and not in the context of how these services can be more inclusive and accessible, and also in the context of impact, if there are data on these referrals that you mentioned. If, of course, I know there are cases, but I'm just wondering if there is a record of the data and the referrals, and actually, the follow-up. Given that this population have a lot of needs, talking also about migration population, also legal services or other things. And then the other question is mainly for the researchers and is linked a little bit also with the comments you made about the political support and buy-in. I'm wondering if in your research there are also data related to the perception of safety of the community around the areas where such centers operate, and how all actual data related to the criminality and crime rates and this, because we know, drug use in the street, and this is also linked a lot from the, community safety or actual safety or perceptions of safety. And this is very critical on the stigma and the acceptance of this type of services. So I'm just wondering, there are such studies that you came across in your research that they linked also the DCRs with this angle.
So you'll be pleased to know there's two sections that I think would be relevant to you in that report. The first, and I think one of the most interesting studies that I enjoyed reading, was actually from Australia around community perceptions. And it was in relation to the Sydney service. So about 18 months after the service had opened, so it's been operating, you have all those teething problems as it settles into the wider community and network. About 18 months after, people living in the same area where the OPC existed, half of them couldn't tell you where it was accurately on a map. And 1/3 of businesses who probably would know a little bit more about what's happening in the area, about 1/3 of them couldn't point it out on a map. So these things can coexist so nicely within the wider sector. And there will be teething problems as these things open, but partnerships with community groups, with businesses, with the police, with residents, this is what the secret sauce is. And really being open to dialogue, being open to questions, and particularly when you were talking as well about maybe having a slightly more hostile media that uses terms we wouldn't want to use particularly. The evidence around crime, there's also quite a bit of evidence around for crime. Again, we center around primarily Australia and primarily some of the Canadian approaches. And even when they're looking at control areas that are similar to where the OPC or the drug consumption room is located, we don't see increases in crime. Now, this is much more of a contentious issue, and people have very strong opinions about the nature of the evidence and the quality of the evidence. And we also discuss that because I think it's important to discuss those controversies in the report as well, and not just pretend that everything is beautiful. But we talk about how some of those evidence is used in practice. But the broad brush is that we're not seeing differences. But if you want to have another conversation, I'd love to bore you to death with the details. Maybe I'll not bore you to death, but there's a lot more in there, and I'd love to have a conversation with you about it after. Thank you.
So just to your first question in relation to the evaluation.
Sorry.
No, it's okay. Just in relation to the evaluation. So it's a very small sample size that we had, but typically the average age of people who were involved in the focus group. So these are people who came every single day to the DCR, regular attendees, connected with a lot of the services. The average age was 44. so quite a bit older, whereas the people we interviewed on the street, the average age was 26. So again, again, it was only 25 odd people, but it seemed to be a much younger cohort who didn't necessarily feel ready to come to the DCR yet. And that's something that we wrote about in the report, what can be done to try and increase that engagement. And yeah, just a really interesting point on those differences.
Just adding to our beloved guest, I would like to tell you that during our effort to exist in a neighborhood, we are having several appointments and several meetings with people who live in the neighborhood, the people who work and have businesses there, as well as with the people who are drug users and they use our services. Many times I go also there and meet the businessmen of the area in order to express, to hear them, to listen to them, and to see how they feel and how they if they have problems with the existence of and the operation of the DCR, and as well to inform them what kind of services are being provided within the DCR. I would say that we have reached to a point that the people who are working there, who are living there in the area, send us people of our interest to the DCR. It's not always easy because there are some people who are of another mentality, but it is very well, let's say, accepted now. And we are almost 2 years functioning there.
Actually, that was also my point, to what extent we use this data that shows that there's no increase of criminality, if not reduction, to basically counter this type of perceptions in the media and political discourse that, you are creating, I don't know, hotspots of crime by creating DCRs in our neighborhoods. And the importance of somehow document this and use this type of data also in the public discourse.
The thing is that here I would add also the support and let's say the help that we have from the Greek police, where we are like partners. We are not enemies. We are not we are in the same way of thinking. And it's very difficult to have drug possession in the corner and then to get into a DCR where you will use illegal drugs. Okay, this is very difficult consensus of all the parts, but we've made training to the police. We've discussed with police stations of the area. We discussed with high-level police officers, and we are trying to minimize all the barriers that we have, both sides, which is very significant. This means that we have a very well-educated people in police who understand the problem that is a health issue problem, first of all, and then all the others. And these help us in order to function rightly and smoothly. The other thing is that, okay, we gather all the data as you asking. We are gathering all the data, and we have a follow-up where these people are going to go, or what program they will follow, or whatever needed. Yeah.
If I may. My name is Orsa Keliadu, and I'm working in the Human Trafficking and Migrants section of UNODC. And I wanted to ask you about victims of trafficking that you might come across in your services. As you might know, UNODC also has a mandate on trafficking in persons. It is a treaty we are servicing, and we're particularly interested in the context of referral. Measuring prevalence, do you see these people accessing your services? Because all of you almost mentioned that you reach vulnerable people that wouldn't be reached, otherwise. And we have data not necessarily from Greece or Europe, but rather from the US, that points out to the fact that health professionals of all sorts are probably most often the number one point of contact with a victim of trafficking. And in a vast majority of cases, victims of trafficking go undetected and not heard. So I was wondering, what's your experience?
We have many cases that come to our services. The thing is that, as you know, it's not easy to recognize this kind of cases. First of all, they come in order to take some services, and they might never refer to their problem at the beginning. So as the time passes and we have a more concrete and more safe, let's say, relationship, and there is a belief in our relationship with them, they try to share their things that they are concerned, meaning some law issues, some trafficking issues, and whatever. When we have trafficking cases, we refer to specific bodies that are in our country, and if they want to, because for us it is significant to come and take the services and not to leave our support, because sometimes when they are forced, let's say, to refer their problem, they might leave the services. So for us it's not the top priority of the reference, but to take the services for health support. Okay, thank you very much for your patience and your communication and feedback that we had. We hope that you come and visit our DCR and our services as well in Athens. You're all always welcome. Thank you very much.
Thank you.